I'd like to welcome you all this evening to the Hypersomnia Foundation UNIGHT meeting. This is a real privilege for all of us to share with you. We have a wonderful speaker, Dr. Alicia Roth, who I'll let Matt introduce just momentarily. My name's Claire, and I get to work with a great team at the Hypersomnia Foundation. So I'll just run through what we've been up to and what you can look forward to. All right, so this is just, we have to thank our sponsors who very kindly enable us to run meetings like this and other ones throughout the year. So probably the biggest news is that we are going to open our Beyond Sleepy conference registration this week. So please do look out for that on social media and in our newsletter. This is a weekend conference. It is in Seattle. You can see there it's June 6th to the 8th. And what you don't see on this screen is that we're going to be celebrating the second Idiopathic Hypersomnia Awareness Day. So there's going to be lots of activity and energy around that building up to the conference. So do look out for registration. It's going to be $50 to actually attend, and we're just working on a room block this week as well to make sure that it's affordable as possible for people to go. So if you haven't been to one of our conferences before, they are fabulous. Lots of great speakers and a wonderful opportunity to meet everyone. So save the date for June 6th to the 8th and look out for registration this week. Meanwhile, you can also join for free. This is our webinar coming up on March 14th. So we have some great speakers. One of them is Dr. Scammell. He's going to be speaking on IH, and Dr. Anne-Marie Morse is also lined up, and some others. So this is a 2.5 hour, I think, 3 hour. Oh, we've got 3 hours there. It might be 2.5. We're just working on finalizing the details of the program. So you can register for that. That is actually open. So you can just register for free and join us in that webinar. It's going to be all wonderful. If you don't already know, our Supporters for Supporters group was launched this year. So this is like tonight. It is a UNIGHT, but it is specifically for supporters. So if you know anyone in your family or loved ones or friends that really are invested in you and your journey, but would like more information, it's important to chat with other supporters then. These are every month, and the next one is actually March 12th. Registration is open for that again on our social media channels and on our website. We do have a YouTube channel, so we have lots of videos that are being, still released this year. We've been running this for a couple of years now, so they're really great educational content, and you get to hear about patients' journeys. It's called Living With. So again, on our website, you can find all of those accessible there. We have a TikTok channel. If that's your jam, you can follow us on TikTok. We actually really have a lot of engagement on that platform. We're also on Instagram, though, LinkedIn and Facebook. And of course, we have a newsletter called Somnus News. So you can sign up to receive I think they're like at least twice a month. Really a lot of information packed into those newsletters, including all of our events, but also clinical trials and any kind of press releases that's happening out there in the sleep space. So do sign up for our newsletter. We have a registry if you are interested in helping support research. Again, details about that on the website. It takes about 30 to 40 minutes to fill in, but it really does help with research in IH. All right, that's all from me, Matt. I think I'll hand over to you.
Yes, thank you so much, Claire. I think it's time for everybody's favorite part, which is me reading off the disclaimer statement. So please just bear with me as we get through that, and then I will introduce Dr. Roth, and we can get started to the best part, which is, again, the presentation. So our UNIGHT virtual forum is educational and supportive in nature, and will offer self-care strategies to help you in your daily life. However, the group will not engage in rendering any psychological or healthcare advice for any particular individual or situation, and will not provide medical, mental health, or any any other type of health-related service. No diagnosis, treatment recommendations, medication advice, or any other type of medical or mental health recommendations will be offered. Our support group is not a substitute for or alternative to treatment by a licensed medical professional. Always seek the advice of your own physician or another qualified healthcare provider with any questions you may have regarding your medical condition. The Hypersomnia Foundation does not recommend or endorse any specific tests, physicians, lawyers, legal advisors, products, medications, procedures, opinions, or other information that may be referenced on its website or during any online support groups. Every time I read that, I am reminded that my dad is an attorney, and so he's partially responsible for things like this. So now let's get to the best part, which is introducing my friend. I'm going to share her bio with you, and then jump into kind of a personalized introduction. So Alicia Roth, Ph.D. DBSM, is a clinical health psychologist and staff at the Cleveland Clinic Sleep Disorders Center and is board certified in behavioral sleep medicine. She completed her doctoral training at the University of Florida, an internship at Baltimore VA, and behavioral sleep medicine fellowship at the Cleveland Clinic. Her clinical work focuses on treating a range of sleep disorders, including insomnia, circadian rhythm disorders, central disorders of hypersomnolence, and nightmares. She has published numerous research articles on the intersection of sleep and chronic health conditions, such as fibromyalgia, heart disease, and persons with Alzheimer's and their caregivers. Dr. Roth's current research focuses on the implementation of population health initiatives for insomnia treatment, as well as developing treatments for central disorders of hypersomnia. In 2022, she was awarded the Society of Behavioral Sleep Medicine's Early Career BSM Advocacy Award. Also, just want to share personally, there are only a handful of real experts in the behavioral sleep space when it comes to central disorders of hypersomnia, and we are truly blessed to have Dr. Roth here. She's not only a brilliant researcher, but she's also a great friend and a champion for people living with narcolepsy and IH, and any sleep disorder really. But it's truly an honor to have you. It's it feels weird calling you Dr. Roth, but because I love to text you and just catch up on everything. But again, blessed, honored to have you here, and so I will turn it over to you to drop some wisdom.
Drop some wisdom. That's what I'm here for. Well, let me share my screen here. Well, welcome. Thank you for that really lovely intro, Matt. I'm so happy to be here again at UNIGHT. I think this is a really important and sort of overlooked area of what the experience with hypersomnia is, even though we talk about it a lot and we investigate it a lot. From my perspective, the behavioral sleep medicine and sleep medicine in general, we're not doing a lot about it. So I wanted to talk about that. For those of you who don't know, there is such a thing as a sleep psychologist. I was trained as a clinical health psychologist, which means I have training in the intersection between mental health and medical disorders, medical problems. So in my training, not only did I learn about sleep disorders, but I learned about pain, transplant services, oncology, multiple sclerosis, bariatric surgery, any kind of specialty within a regular medical center I've probably been in. But I really love behavioral sleep medicine. I think everyone has some experience with poor sleep, and this is a much more easily empathic condition for everyone to be empathic about. Yeah, so sleep psychologists, we don't just do insomnia, and I think that's something that we're trying to get across to the public, is A, that we exist, and B, that we're more than insomnia. And for the truly expert BSM providers, those who have a diploma in BSM, that's the DBSM, it's a board certification. We really know everything in sleep, and that includes treating people with central disorders of hypersomnolence. So today I'm going to talk more about what we know about mental health disorders of hypersomnolence, and including what can we do? What's next? What are the next things to actually do? I think we know that very well the research of what's happening, but we don't really know the research of what to do. We don't know the right things to do from an empirical standpoint at this point. So what we know about psychosocial functioning is that persons with CDH just have a horrible time getting to a diagnosis. There's a lot of misdiagnosis, and with that comes a lot of frustration, comes a lot of time not actually treating the real problem, and a reduction in functioning overall. We know that people with CDH have psychiatric diagnoses, more commonly diagnosed with psychiatric diagnoses than the general population, that they face stigma and negative self-esteem and difficulty in relationships and occupational problems in school or work. And for everyone here, this might be like a common sense thing, but it is important that we know that we have captured all of this in an empirical way, in a scientific way. I really like this next study because of the title, mostly the humanistic and economic burden of narcolepsy, because I really think it is burdensome. Now, this particular study only looked at people with narcolepsy. It was a huge survey of over 176,000 American adults from the US Health and Wellness Survey, I think back in 2013. And there was 437 people who were diagnosed with narcolepsy, and then they matched them with like age controls. And what was interesting was people with narcolepsy were nearly twice as likely to report depression. And you can see the rate for bipolar disorder, also pretty high, 14.2%. And more than twice likely to report any type of anxiety disorder as well. So that's evidence that, you know, people with narcolepsy have more of these diagnoses than the average healthy adult. We specifically know that evidence shows that hypersomnia disorders are very detrimental to the mental health of young adults. Just wanted to highlight this study back from 2015, comparing a subset of young adults with and without narcolepsy. And it showed that the young adults with narcolepsy experience significantly more perceived stigma. And so this was a study where it was young adults, so in their 20s. I think the average age for the narcolepsy patients was 27, and the control patients 25. It was majority female, majority white, and again, only narcolepsy diagnosis here. But you can see that there is, for all of these variables here on the left side, they are significantly different between these groups. And patients with narcolepsy had higher social rejection, financial insecurity, internalized shame, social isolation, and disclosure concerns about disclosing anything about themselves, not necessarily epilepsy diagnosis. And all of these comparisons were statistically significant comparisons. And then similarly, a study out of Northwestern around the same time showed, included people with narcolepsy, didn't compare them against controls, but showed these very, very high rates of mental health symptoms. These are just broad mental health symptoms: sad mood, loss of interest, irritability, social isolation, concentration, guilt, worthlessness, anxiety, worry. So these aren't necessarily like formal diagnoses of mental health conditions, but they are symptoms of poor mental health. The Northwestern group also did a series of focus groups looking at people's perceptions of what they're experiencing as far as their psychosocial functioning as a person with hypersomnolence condition. So this included people with both types of narcolepsy and IH. And I think they broke it down into these 6 domains of like where people were struggling the most. There are some quotes here from these are quotes from actual participants in this study. So people have problems with negative perceptions. People say, I don't think you have narcolepsy. I think you're just tired. They have problems with self-esteem and self-efficacy. I feel like I've gone in my head from someone who is capable to someone who's not capable. Example of that, their social life. I can't keep in touch. I can't follow through. I can't meet up with them. I can't be invested. And it has ruined relationships too. Occupational functioning. The need to sleep is so strong that you think, well, I would rather lose my job and be homeless if I have to because I have to sleep. Family planning and relationships. I'm scared to pursue any intimate personal relationships because of my cataplexy. And physical symptoms. This is one of my favorite quotes from this particular paper, and I think in general about what we're learning is it's almost like we're addicted to sleep. And the only way to feel better and rid that craving is to close our eyes and actually fall asleep, but it never goes away. And again, I think for all of you joining this call today, a lot of these things are like, yes, we understand, we live this, but I think it is very important that to know, and this is by no means an exhaustive review. There's a lot of scientific evidence, scientific studies, empirical studies where they really do investigate the psychosocial and mental health aspects of the different hypersomnia conditions. But the clinical guidelines for how to treat and assess people with hypersomnolence conditions aren't really caught up to all of this wealth of knowledge we have now about the mental health of people with narcolepsy and IH. So we're looking at the American Academy of Sleep Medicine, ASM guidelines. They have guidelines for, most sleep disorders as far as they do a big working group when they do these guidelines who do a massive literature search of all the available research literature. And there's a special way to decide, what treatments have good evidence, strong evidence, which research has or treatments have conditional evidence, and which treatments have strong evidence against or weak evidence against. There's a whole range of recommendations, and they get together and they try to, they're not, it's not experts getting together and it's their opinion on what the treatment should be. It's really based on the literature that's available. And so in 2007, the ASM guidelines, there's only a short paragraph on any sort of behavioral treatment. And it really doesn't recognize anything that we just reviewed in terms of what people with CDH are struggling with. And it's not because they don't want to recommend it, it's because that the research isn't there to recommend a treatment. There hasn't been the trials needed to recommend any sort of mental health treatment for people with CDH. And so what's available in the 2007 guideline? It's scheduled naps in narcolepsy for people who remain sleepy despite the use of medications. Regular bedtimes, 2 15-minute regularly scheduled naps. I mean, this is very bare bones kind of behavioral treatment. It doesn't really address the mental health. It's more about behavioral treatment to help with symptoms. The new 2021 guidelines, the authors did the same thing. They reevaluated all of the evidence. But again, not really anything in these almost 20 years, not really anything to add as far as behavioral treatments for CDH or mental health treatments. But we know that people are trying. People with CDH are really trying to help themselves, help manage their own symptoms, and help manage their own mental health. This study, again, same study from a Northwestern group from 2017, they looked at 371 individuals with either narcolepsy or IH. And they found that in that top table, table 4A, it says most people, over 80% of the sample tried daytime naps. That was the most most used non-pharmacological strategy. Scheduled nocturnal sleep, caffeine, exercise, diet, temperature manipulations, chewing gum, nicotine, mindfulness. It took us a while to get to anything mental health related. Mindfulness, yoga, don't use any. And then they rated how effective these are. So on a scale of 0, not effective at all, to 10, most effective. And daytime naps were the most effective, but the average was a 4 out of 10. That's the most effective thing that these patients had. And it was only a 4 out of 10. And, again, none of these are addressing the mental health. They're more addressing the symptoms of excessive daytime sleepiness and trying to function during the day. To wrap up this first part of my talk, I just want to again emphasize there is so much research out there showing us we don't need to prove that this is what this population is going through. I think that research in the past couple of years, with the help of these wonderful peer-supported organizations led by you all, we've proven, I think, almost beyond a reasonable doubt, that there is a lot of suffering happening in this group. And now I think we need to move on to action and provide enough data and enough trials for our colleagues at the ASM to have something to review when they get to the next clinical guideline. So let's talk about there's sort of 3 areas that I want to talk about as far as what's next. Now, I wanted to highlight 3 new studies that just came out hot off the presses. 2 in 2025, 1 in 2024. So this was just published, and it's showing new evidence for how important social and peer support is. So this is Julie Fleiger's group. They had 1,300 participants with both narcolepsy and IH. It was across 30 different countries, which is pretty impressive, although 65.5% was still in the US. At the time of their diagnosis, 91.8% do not know another person with the same diagnosis. And at the time of doing the survey, 37.2% of the people still didn't know another person with that diagnosis. And I'm going to show you some figures from this study because I think it's really interesting. So these are figures from the actual study. So in the boxes up here at the top, the dark green is not supported at all, and the light blue, light purple is extremely well supported. So you've got, variations in the middle. And you can see that overall, people felt somewhat in the middle as far as being supported. So overall, all 3 types of diagnoses, people feel kind of in the middle about being supported. And then for every diagnosis, it ranges a little bit more. It seems like people with type 1 narcolepsy feel like they have more support than the other two specific diagnoses. And this is all types of support: social support, family support, peer support, and medical support as well. What's really interesting is that some of the support depends on different factors. So what you're seeing here is an odds ratio analysis. So when you see that there is a variable that's in this light blue, it means that this is a significant factor influencing support. So if you were between the ages of 18 and 30 years, you were more likely to have more support. So in that young adult range. If you were married, you were more likely to have more support for you with your experience with hypersomnia. Interestingly enough, the rest of the world felt more supported than the US in terms of their hypersomnia symptoms. And people with narcolepsy, oh, I'm sorry, no, I misinterpreted that. The rest of the world was less, so we're on the left side. Interestingly enough, the United States isn't that much more. If you can see the dark blue box, we're not that much more likely to have support, but the rest of the world is, I'm sorry, unlikely to have support, less supported. And just like we saw in that graph, narcolepsy type 2 and IH were less supported. So if you have narcolepsy type 2 or IH, you're more likely to be less supported. But people with narcolepsy type 1 didn't have a significant predictor of being more supported. And then finally, knowing someone with the same diagnosis was a very powerful variable for feeling more supported. And this is just part of this this study from this group, but these are the things that people talk about, were discussed with other people. Treatment options, tips and tricks for daily living. When they talk to each other, I'm sorry, just to clarify, when they talk to someone else, a peer with another hypersomnia diagnosis, understanding the diagnosis. This is going in order, I think, from most people doing this. Lifestyle adjustments, NATs, relationships, work and school accommodations, communicating about your diagnosis. There's some more here. Mental health, kind of solidly in the middle. Healthcare providers who are specialized in these disorders, driving, finding more resources, the science, treatment access, insurance issues, managing other medical conditions other than hypersomnia, pregnancy or parenting, media and entertainment, and social security disability. So peer-to-peer contact is really important. We're talking about a lot of really important things. They're talking all of those things that I was just saying are really can be functionally impaired in people who have a hypersomnia diagnosis. These are what the peers are talking about, and it highlights the importance of that peer support. Another study that was just published was a smaller study, 106 young adults with IH specifically. And it was just looking at their social life, like how does IH affect their social life? And no surprise, 98% reported IH made their social life a lot harder, especially with friends and romantic relationships. 56% reported They had too few close friends. 92% reported IH made it entering into a romantic relationship harder. 37% said IH contributed to a breakup. And this was really interesting. This measure of loneliness, 80% met criteria for loneliness, and 50% reported isolation. So this study wasn't looking at peer support of hypersomnia conditions, but looking at just general social support and how people with IH don't feel like they have a lot of social support in general. And this was published by Dr. Munt's group. It was published at the end of 2024. She has talked about this study a lot, though, so many of you may have heard about it before, but it was just published at the end of the year. But this was looking at people who had a family member with IH or narcolepsy, 100 adults with a family member with a hypersomnia condition. Overall, people felt dissatisfied with the support and their info available. Most of their information is coming from hypersomnia organizations. It is still a high percentage coming from medical professionals, but 69% versus 61%. Their own support, so the family members, their support is friends and family. It's not necessarily other people with hypersomnia, but it's their own friends and family. And they provide a lot of support. These 100 adults that were served, they pick up meds, attend visits, remind their partner or their family member to take their medications and help them coordinate care. And Jen did a really nice overview of the free text that people gave, just what their experiences were. And she did a thematic analysis looking at, what are the common themes that people brought up. And it was really interesting. Conflict and confusion pre-diagnosis of the hypersomnia condition, and then needing to adjust their expectations for their partner or their family member afterwards, and that they overall feel a lot of caregiving strain. So 3 new studies showing that social and peer support are lacking, but also very, very valuable and important. So now I'm going to talk about what's next. What can we offer? What can we do? What can we offer in behavioral sleep medicine to help people who have hypersomnia diagnosis? So I don't know if many of you are familiar with this research. Came out of Northwestern. Jason Ong, Ariel Nykrug, Jen Munt, Spencer Dawson, this group, many more people, I'm just name dropping, many more people worked on this, but this is called cognitive behavioral therapy for hypersomnia. We call it CBTH for short. You may have heard of CBTI, that's CBT for insomnia. This is CBTH. Now, this is designed as an adjuvant treatment to improve psychosocial functioning, improve all of those things that I was just talking about before in terms of what affects people with hypersomnia. And an adjuvant treatment means we don't think this is going to cure the condition of hypersomnia or IH or narcolepsy. It is to improve quality of life. And it is not a substitute for other treatments like pharmacological treatments. It is an additional treatment that can improve quality of life. So they did this really nice build up to testing CBT for hypersomnia. They did 3 studies. First, they did a survey asking people, what behavioral strategies are you using to manage? You saw some of the evidence from that before, the naps, and the naps being a 4 out of 10. That was that study. And then ask people, what is your interest in something like this? If we design something like a CBT for hypersomnia, what would be your interest level? And people were interested. So then they escalated and they went to do some focus groups, had some groups of people sit down. They uncovered themes related to quality of life with hypersomnia and asked, again, what would you like in a psychosocial treatment? And I love that they took the time to really get the people who have the most at stake, get their feedback. I don't think that that's always true in other parts of medicine or even psychology when we're designing new studies. I think it's very unusual to sit down and do focus groups with people and like, what do you like about this? We just do the study and report the numbers and report the science. But I think we meaning science and psychology, we just recognize how strong your organization is, the Hypersomnia Foundation, and how strong and connected and passionate you all are. And we want to include you every step along the way when we're potentially designing something that could be helpful. We don't want to just recruit you for our studies and then publish the research and publish the numbers. We want you to be a stakeholder in this from the ground up. So once they did those studies, they actually designed what CBT for hypersomnia should look like based on their feedback. And they found that it was a very small pilot study, but they found that CBTH decreased depression symptoms. This was a feasibility study, so they were also testing out, do people like individual care versus a group care? They found that the group format might be more effective. This was before the pandemic, so they also kind of tested out telehealth. And I don't think that they were really focused on telehealth as much as we are now, as connected as we can be in telehealth. But overall, it had a very high acceptability. And they did a great job of stratifying by diagnosis. So they had type 1 narcolepsy, type 2 narcolepsy, IH, and they reported all of their results, based on the total for the group, but they wanted to see, does one particular diagnosis benefit more than others? They didn't detect that difference in their study. So what is CBTH? I know this is a lot of text and it might be very small, but it's about 7 to 8 sessions, or 6 to 7 sessions rather, of topics that they found that were very important based on their focus groups. So the first being education about CDH, the second, self-identity and self-image. So discussing changes that have developed as a result of their diagnosis and their symptoms, strategies for acceptance and value congruent living, which we're going to talk about in a moment. Structured daytime activities for session 3, and then structured nighttime activities. So this is more about symptom management, these 2 sessions. The structured daytime activities, helping you make the most out of the limited time that you might have as far as your energy and your alertness, and actual ways to structure activities that you need to do and testing that out for yourself. And then nighttime activities, making sure you have a good nighttime routine. Coping skills and emotion regulation. That is a very important aspect that we learned through all the decades of research, is that just coping with the experience has been really, really difficult for a lot of our patients. Social support. And when I've done CDH with patients, my pitch for social support is a lot about your organization and the other care-led hypersomnia foundations, the medical, legal, and occupational issues. That's not something that we usually include in a psychological treatment, but is so relevant. So many people working to be on disability or learn about accommodations for their work, or learn about careers that they can do, or how to change the careers they're already in to accommodate for what they're going through. But I think that the authors left this kind of open in terms of how you could structure it. There's other topics here, including cataplexy, medication adherence, talking about the impact on family relationships using emotional support animals or service animals. But I think there's a lot of flexibility in the order that there's no, rhyme or reason to the order of this or what you include in each session. But this is, as far as the research of CBTH goes, is this one feasibility study that was conducted or published in 2020. And so there have not been any more trials of CBTH. This was only 35 adults too, with all different types of diagnosis, but only 35 people did this. So we certainly need more trials, more rigorous trials for CBTH. In my own practice, I have not been able to do the scientific work, the trial work needed, but I have been able to launch some CBTH groups in my own clinical work. In the groups that I've done, it's usually 3 to 4 people. I try to get all diagnoses represented in each group. I do 6 weekly sessions, so I kind of just condensed that session list. I think, the way I condense it is I do the structured daytime and nighttime activities together. And we do it in a group, and we do it via Zoom, via telehealth, which my patients have said is the only way they could possibly do it. Mostly because, after the pandemic, we are much more able to see people virtually. My patient takeaways is, they want to talk about sleep inertia, productivity, they want to talk about symptom management and some of the technicalities of disability and accommodations. But my patients that have been in this group, the first 2 groups I had, it was 7 people altogether. None of those 7 people had ever met another person with narcolepsy or IH. This was their first time meeting someone who had a similar diagnosis. That was huge. Beyond the symptom management, my patients usually take the group over and talk about a lot of different things: loss, grief, loss of careers, their relationships, their health, anger. They talk about managing their current relationships and whether that's their role as a parent or a spouse. Whenever I talk about symptom management, I usually kind of get like, okay, yeah, that's good, that's all good. But when we start talking about these more, I think, mental health oriented, quality of life oriented topics, and topics about values and how their life is going, that's what really got people engaged and interested in the session. So I started to think, how could I do this better? Every time you do a group, you're like, okay, what worked, what didn't work? And I was like, okay, well, I have to run these groups focusing on people's experience and living the best life possible. They do not want problem solving or hacks. They don't want to teach me how to stay awake all day. That's not what I was getting. I think that's what most physicians assume that people with narcolepsy and IH want to hear, is how do I stay awake for as much as possible? How do I manage that one symptom of excessive daytime sleepiness? But there is so much more underneath what's going on with these patients. So I have started to take an acceptance and commitment therapy approach. So I want to go over more about what is acceptance and commitment therapy. I've kind of given a talk about this before, but I haven't really gone into a lot of detail about what acceptance and commitment therapy is. It is a very tried and true treatment. We know it's effective across a range of chronic and or incurable health conditions. And I think narcolepsy and IH fall into that category of, this is not something that's just going to go away or be cured spontaneously. It's not going to be cured at all. It's something that you're going to have to live with lifelong. And so we have to figure out a way to help you live the best life possible. So if you know anything about ACT, ACT is a lot of metaphors. They love metaphors in ACT. So I'm going to teach you what ACT is through a couple of metaphors and comparisons. One way to summarize what ACT is the Serenity Creed. Have you all heard of the Serenity, or some people call it the Serenity Prayer? So grant me the courage to change the things I can, the serenity to accept the things I cannot change, and the wisdom to know the difference. And the work of ACT is really the wisdom to know the difference, right? That's the work of this therapy. The more you struggle to fix what cannot be fixed, the more you suffer. And in this example, it's, you know, the more you fight against the diagnosis of hypersomnia and the symptoms of hypersomnia, the more you engage in a fight, the more you're going to suffer. ACT is based also on this idea that it's very easy for all of us to engage in what we call experiential avoidance. So we're all guilty of this for different things in our lives, avoiding a situation or certain emotions or trying to escape an experience makes you more mentally averse to the experience. The more that you try to suppress it or run away from it, the scarier it gets, the more fearful you become. And with ACT, we are trying to learn how to accept. So accept is not giving up. Okay, so a lot of people think when I talk about acceptance therapy, they're like, okay, you just want me to like just give up and live my life and, you know, who cares, I have hypersomnia? No, it's willingly engaging with the experience of having hypersomnia. Another way I like to say this is it's living parallel. You and your hypersomnia have to live side by side. And how can we do this and make sure that you get to live the life you want to live? Once you accept and live parallel, you get the choice. So rather than live in opposition to your symptoms and your condition, now you're free to choose how you live. And then it's about taking action. Let's take steps to go in the direction you want your life to go in. Another metaphor for this is the finger trap. Does everyone remember these finger traps? I don't know why I always pick these at Chuck E. Cheese. This was the banger for me at Chuck E. Cheese. But if you remember these, or if you've never seen them before, it's like wicker almost, or yeah, like wicker, and you put your finger in, and if you pull your finger out, it gets trapped. You can't pull your finger out, and if you pull and pull and pull and pull and pull, you're not going to get your finger out. The only way to get your finger out of this trap is to stop pulling and relax your fingers. And then the trap opens and you can move your fingers wherever you want. This is a metaphor that we use a lot in ACT. So once you stop fighting, once you stop willingly engaging in the battle, you're free. You're free from it. I'm going to use one more very common metaphor to explain what ACT is. And pardon me if you've heard of this metaphor before, But this is the passengers on the bus metaphor. So imagine you're on a bus and you're the driver. This is your bus. You're the driver. You're the only one who can drive this bus. You determine the speed and the direction of the bus. And down the road ahead is a life you love, full of all your values, relationships, challenging work, contributions to the world. This is the route that your bus is on. But just like many buses, there are passengers. And these passengers on your bus are made up of your thoughts, your emotions, your sensations, memories. They've all hopped on your bus at some point. Now, some of these passengers are helpful. They happily come along for the ride and they don't bother you. But some of these passengers are meaner, bossier, louder, unwelcome. They tell you when to turn left or right, or when to stop, or where to go. Now, imagine that there's one particular passenger. Let's call her Hypersomnia. Hypersomnia comes right up to the front of the bus and tells you where to go and how to go there. And this passenger is very persistent and can be very loud and aggravating. You can't ignore this passenger. It tells you you're not good enough. It tells you you'll not be able to drive without explicit directions from her. So we've got the passengers in the bus. And one thing that we might do is just listening to what that obnoxious passenger says, right? They're so bothersome and horrible. You're trying to get them to stay quiet, right? So you can drive your bus. So you might just do what they say. They offer you a deal. If you follow my instructions, I will stay quiet. In the short term, this works, right? But it doesn't, she doesn't stay quiet for very long. And while you're focusing hard on making sure you're doing what she says, you're not making progress down the road you want to go, because you're listening to what she's saying to you. Another thing you could do is you can fight with this passenger to keep it quiet. Argue or reason with her, or try to outwit her, or plead with her to leave you alone. If you could just win this argument, they might get off the bus or at least be quiet, but you can never win this argument. Hypersomnia, this passenger has all the time and the energy in the world to yell at you and fuss at you and tell you what to do. So the more you fight with this passenger, the more energy and focus you give the passenger, while you get worn out. And again, you might not be going down the road you want. And as you listen to your passenger, this obnoxious passenger, you might get farther away from your intended route towards what's valuable. Now, for many of you, the passenger might be hypersomnia, but the passenger can be self-criticism. It can be pain, like physical pain. It could be depression. It could be lack of self-compassion. The passenger is sort of the issue or the problem that is bringing you to treatment. With acceptance and willingness, which is like the core of acceptance and commitment therapy, you acknowledge that hypersomnia passenger is on the bus. If you can tell very subtly, I moved her to the back of the bus. She's there, she's loud, but you acknowledge and you understand I'm driving the bus. And we're going to continue driving towards the things that are valuable to you. No matter the passengers on the bus, you're the driver and you choose the route that you want to take. The hypersomnia passenger is still loud and obnoxious, but you choose to stay on the route and move in the direction of your values. One of the things that we talk about a lot in ACT are what are the things that are valuable to you. There's one exercise that we do. It's kind of morbid, but it's let's plan for what people what you want people to say at your funeral. And you have one friend talk about how good of a friend you are, and one, your child talks about how wonderful of a parent you were, and your boss says you were so committed to your job and helping other people. And those are the values you have. Those things that you want said about you are the values that you have. And for most people, they don't say, I want someone to get up and talk about my pain. I want someone to get up and talk about my depression. I want someone to get up and talk about my medical problems. Or I want someone to get up and talk about my hypersomnia, and how it ruled my life. Those are your values. Values are not things that ever get checked off. Being a good parent, you never say, oh, I'm a good parent, done. You never say I'm a good spouse, or that I'm done contributing to the world, right? Values are the things that just drive us. Now, there are goals to get to those values, but the values are always the compass. And what we're doing in ACT is uncovering what those really are. And I will say that when I work with patients, they're with IH or narcolepsy, most of them are not telling me that they very much value managing their IH symptoms. That's a value to them. It's something they have to do, but that's not what keeps them going. That's not valuable to them. And so when I work with people who have these diagnoses, we're first uncovering, like, what's the route? What's the bus's route? And it might not be a route that you've been on in a long time or ever, but let's figure out what the route is. And then let's figure out what are the things that are getting in the way of driving that route. So I have many more slides on ACT that I could go through, but I'm going to stop here because I want to give people the opportunity to ask questions. Just two more things about ACT. Most psychologists can do this treatment. This is a very popular, well-researched, and well-disseminated treatment. So if this feels like, oh, this is something I want to try, or I want to tell, my friend or family member about, you can easily find a provider in your area who does ACT. Now, they might not know a lot about hypersomnia, but there are a lot of people who know how to do this treatment. If you're interested in just learning more, so the founder of ACT is Stephen Hayes, Stephen with a V. And I'm sorry, I didn't put this on the slides, but this is one of like the first and seminal workbooks. This is a workbook for you as a person who wants to learn more about ACT. It's called Get Out of Your Mind and Into Your Life by Stephen Hayes. It's thin, it's very user-friendly, but it's walking through all of the aspects of ACT, and it's very general. It's not about a specific problem. You sort of fill in the blanks with the issues that you're bringing to the table. It's a wonderful workbook. I would say most clinicians have this in their library. And with that, I will stop.
Thank you so much, Dr. Roth. I think we've got about maybe 10 minutes or so for some questions before we do some breakout groups. Again, one of the things that can be challenging, you want to ask like personal questions, but if we can keep things kind of broad for the whole audience, that would be great. Does anybody have any questions? I made sure to tag most of the research that was referenced throughout the presentation there. But anything about, behavioral interventions for, yourself, or what we can share a little bit more about what has worked for you when we do breakout sessions themselves, but some good questions maybe about how to get started too. I see that Pilar has a question, so if you want to go ahead and ask your question.
Sure. So I was wondering, I like how you introduced ACT as a method. Have you considered solution focused therapy?
Yeah, very similar. Difference is ACT is so much more about not seeking a solution. ACT is more about you're not necessarily seeking a solution to a problem with ACT. It's more of overall, how do I live the life that I want to live? But solution focused therapy is very popular and would absolutely be applicable. Could you tell us a little bit more about that? Could you tell the group a little bit about that?
Yeah, sure. I took a continuing education course on solution focused breath
Mm-hmm.
therapy, and I really loved how the presenter spoke about it and spoke about living a solution focused life. And I was
Mm-hmm.
really attracted to it. And then I realized that as a result of my IH, I had been applying
Mm-hmm.
solution focused methods.
Mm-hmm.
And the more I read about it, the more I'm like, it just makes so much sense to use solution focus, and especially in a society that's so problem focused and other modalities that's again so problem focused. Solution focus is more about like the here, the now, the future, and like you're looking at your strengths.
Your
And
strengths,
so
yeah.
it's yeah, so it's a very strength based perspective, and I personally I love it.
Yeah. I know I love strength-based therapy, and I do incorporate that when I'm working with patients with hypersomnia is tell me about a time that you struggled with something else and how you got through it. Tell me about what going to college was like for you, not so much how you struggled through college, but how did you make it through? And learning from the patient of things that they've already done makes it actually easier for you as the therapist, because you're like, okay, so you've been in a situation like this before and you've applied X, Y, and Z. Let's try that again and just direct it towards something else. But yeah, no, that's a great therapy.
What kind of questions would you think I mean, there's wonderful, great sleep physicians or sleep specialists across the country, but there's not a huge number of them. And you may find yourself in a region where there's a resource desert in terms of a behavioral sleep specialist.
Definitely.
What sort of question would you encourage any of the people in the audience to ask one of their local therapists, whether it be a psychologist, a clinician, or whether it be someone in the social work field or a therapist, because it
Mm-hmm.
seems like they're all capable of utilizing similar
Mm-hmm.
modalities. But what sort of screening questions would you ask? And I know there's going to be an education piece from the person, but I would love to get your idea of how do you go in and just bring this
Yeah.
up.
I think first and foremost, you can, when you're looking for a mental health provider, one great resource is Psychology Today, their website. And if you're listed as a provider on Psychology Today, you generally write about what you're capable of doing and the types of treatments you're able to do. And so you can sort by, providers who offer ACT therapy specifically. Before you even have an appointment with the person, so that you don't waste your time, you can usually see on their website, what their focus is and what kind of treatments that they do. You can ask ahead of time, is this something that you're trained to do, so you don't waste your time going to a session. But if you do make it to a session with someone who says that they're ACT trained, asking them, what's your experience with this? What kinds of conditions have you treated before? If they don't have a history of working with people with hypersomnia, even if they had a history of working with someone who had a chronic medical condition, that is like an incurable condition, they would be in a really good place to help you. the hard part is that and I know that this is sometimes something you don't want to do as a patient, is you're going to be teaching them a lot about what hypersomnia is and what your life is like, and they might be learning from you as they go along. But all of the foundation is there and the framework is there. It's just about not seeing, having seen that patient before. So I think there's some legwork you could do even before you get into the session, but just asking like I think asking what kinds of conditions they've treated with ACT would be very telling about how they might do with hypersomnia.
Yeah, it's a great point. I've found helpful, like with the chronic disease or conditions, there's some overlap or an easier pickup. And I know that you and I have talked privately about, that how chronic pain has been utilized successfully in ACT among a whole slew of other conditions.
Yes.
Mary, I see that you have your hand up. It's great to see you. Well, not yet see you, Mary, but it's great to have you here. Feel free to ask away.
Yeah, hi. It's good to see you
Hi.
too. So I was just curious. I know a lot of us with hypersomnia, narcolepsy, and the like, we might not have insurance, or we might have kind of crappy insurance, or not really have the ability to be able to pay, however much it costs to get this kind of therapy. What kind of suggestions would you have as something we can do, either as a placeholder, or like maybe to get help with the cost, or like how would you advise somebody who has like a financial burden or a financial hurdle?
Sure. It's hard. A lot of the most qualified BSM providers are now behavioral sleep medicine providers are in private practice. Some of them have sliding scale, which means that you pay based on you pay a price for sessions based on your need. So that's always something you can ask. If you think that there's a really great provider that that you want to work with, whether they're BSM or otherwise, you can ask, do you do sliding scale payments? And a lot of people do. Again, Psychology Today is a good source of, because usually people list what insurances they take, so that you can know ahead of time. So if you don't have insurance, seeing what they'll charge, either sliding scale or out of pocket, or at least just knowing ahead of time. Maybe they take no insurance, because a lot of practices take no insurance. But if you feel like that the barrier to actually seeing someone is significant, I would say that there's just so many great ACT workbooks out there, like the one that I shared here, Get Out of Your Mind and Into Your Life. This is an oldie but a goodie. It never gets old because it's so good. And it's just the very it's very user friendly. It definitely helps with a lot of these concepts in a straightforward way. The thing that I like about this book is it's not like a textbook. It's exercises. It's okay, let me teach you a concept, and let's do a little exercise together. And it walks you through a lot of exercises. And so it's not just a textbook. It is a workbook, really. So anything by Stephen Hayes, because I know he has a lot out there, is going to be really high quality as far as a self intro into it. And it might be because you want to manage your resources best, that maybe you do this self intro and see if you like this, if it's the right thing for you before investing money, or in seeing a provider. See if you actually like this first, before you take that step.
Great points. Looks like we are coming up on time where we want to jump into some breakout rooms, but I did just want to give you just huge gratitude, appreciation, and kudos for coming and sharing. And you're a wealth of knowledge. Is there any recommendations you would offer in terms of, like, if people want to follow some of your work? I think you're on LinkedIn and a few other places. So feel free to plug if there's any place that we can find you.
I don't anymore have a lot of social media. But I will hopefully be at Beyond Sleepy. I'm very available to kind of guide people to where they want to go. So if you have a specific question for me, maybe y'all can field questions to you and you can get them to me. But I'm very happy to be helpful in whatever way I can to getting people to BSM services or the right spot for mental health care. But I will be at the Beyond Sleepy conference and the big sleep conference in June as well. So if you see me, please come up to me, talk to me, say hi to me, ask questions.
Yeah. I will fully attest. She's very approachable, and she also is great about answering your questions as they come. So thank you so much. And for everybody in the audience
thank
too,
you so much.
Yeah, thank you.
Thank you.
Amazing. Thank you.
I'm going to pass the torch to Claire so she can do any sort of wrap-up comments or announcements.
Yeah, thanks, Matt. I think that was such a great session and really meaningful and really thought-provoking. And I said in our breakout room, if anyone's got any ideas as to, whether we want to develop this kind of topic more, have Dr. Roth back. Again, of course, she said she'd be at the conference. We are going to open registration for that this week. So please do really seriously think about joining us in June in Seattle, and of course the webinar that's on March 14th. And if you forget all this, don't worry, it's on the website and it's on social media, all the typical places you'll find the Hypersomnia Foundation. So thanks for joining us on behalf of the foundation and the great team and Matt and everyone. We'll see you next month. Or Matt, maybe you want to finish, sorry.
Oh, no, that's fine. Yeah, we have a few announcements on upcoming events. We've got, there's going to be Dr. Mutt, who we talked about, will be coming and sharing a little bit about nightmares and some other research that she's doing, probably also sprinkle in about the family research. I don't know if you guys saw, but that was my name on that research paper too. I'm really proud of that one. I'm not going to put a whole paper on the refrigerator, but I may print that front page off. And then we also have a comorbidities speaker who's going to be talking about sleep specific comorbidities. So OSA, REM behavior disorder, and sleep related eating disorder, all the ones that can kind of be associated with essential disorder of hypersomnolence as well. And that'll be in June. A fellow by the name of Andrew Spector, who's a buddy out of Duke. In between that, we'll also have some great announcements on the upcoming speaker for March and also May. So just tune into the newsletter. It's a great way to stay in touch.